क्या चाहिए?
हो गया, रीनेम हो गया है।
I've changed, sir.
ओके।
Devarun,
Yes, sir.
could you please call Saranya?
Okay, sir.
Not join. There might be some issue. So people are joining.
Yeah. Lalanji, around 410, 15
Ji,
people
ji.
have already joined. So I think we should start the meeting.
Just
And
I'm waiting for another
yeah,
1 minute and waiting for Saranya to start. Otherwise, I'll start.
Yeah, otherwise you start.
Ma'am is about to join, sir.
Sir, Saranya is joining.
Okay.
Good evening, sir.
So I think now it's 8:05, so we should start. Saranya, are you going to start? Should I start? Okay.
Sir, 400 participants. Shall we start, sir? 4:45.
Yeah.
Okay. Hello, everyone. Good evening and welcome to this session. This session has been planned in such a way that we bring everybody, all the instructors and the course coordinators all across the country on one platform. First of all, I would like to congratulate everybody, not just the organizing committee, but all the practitioners, pediatricians, neonatologists from all over the country for such a great response. We are overwhelmed. Actually, we were not prepared for this kind of a response. This initiative, this session is actually planned so that all the courses, now we have reached about 1,000 courses today, so that all the courses which are done all across the country are they maintain a certain standard of uniformity and quality, and also how to perform and organize this session over 4 hours, which is a stipulated time. So we will have different sessions taken by different panelists that you're seeing on the panel. But before that, I would like to invite our president to deliver his address to the nation.
Namaskar. Good evening, all the respected faculty member, coordinator, and my dear newborn care champion across the country. At the outset, I sincerely thank each one of you from bottom of my heart for your passion, commitment, and dedication you all have shown for this initiative. The overwhelming response to this NRP Day, our key presidential action plan, we have received from Ladakh to Lakshadweep, the remote part of the northeast, Manipur, Tripura, Arunachal Pradesh, and many other places. This clearly shows that we are not just conducting a program. We are building a strong national movement for every newborn in India to receive the first breath in golden minute. So friends, we are coming together with one common goal: to standardize and strengthen newborn resuscitation practices across the country, whether it is the busiest or the remotest one. And we have already reached everywhere. So today's meeting objective is very, very clear: to ensure uniform teaching. So every trainer should speak the same language of NRP. Then hands-on skill need to be reinforced again and again. A strict adherence to the algorithm and ensuring quality over the quantity. This is the most important thing. For that, we have a team of quality control in all the zone who would look into the quality of this course. And finally, every step should be performed correctly and confidently by all our trainers. Friends, we all know that birth is the most vulnerable period of the life, and a delay, even a second, in providing the right intervention can make the difference between life and death or lifelong disability. And that's where NRP becomes the powerful. NRP is not just a course. It is not just a skill. It is a life-saving intervention at the right time in the right way. And today, all of you are here because you are the trainer, influencer, and the leader who will multiply this impact across the country. So particularly, I would like to emphasize anticipation is the key in the preparation. You will be learning details by the different instructor, and the bag and mask ventilation. This is the most critical life-saving skill. And if ventilation is done correctly, we can save majority of the baby who need resuscitation. So my message for all the trainers, we must remember this is not just a lecture-based program. You all know, many of you all are trainer, many of you may have not done for 2 to 3 years. So that's why this course has been planned. So this is not a lecture-based course. This is a skill-based training. So we need to ensure more time on the hands-on practice. There won't be any slide, and all time on the demonstration, a strict adherence to the time, very, very important. And we should focus on PET, that is performance evaluation test. Again, I'll reiterate that the quality training is our priority, not the number. As a trainer, your responsibility is immense. You are not just teaching a course. You are building confidence, correcting the mistakes of the participants, and solving life indirectly. So every participant you train become the lifeline for a newborn across the country. If we do this program correctly, confidently, and from the bottom of heart, I think this NRP Day 2026 will not just be an event. It will reach to the unreached area. And we have already reached unreached. And it will be a turning point in the newborn care in India. So friends, together, let us ensure no newborn dies for lack of timely resuscitation. So with that, my best wishes for happy learning. Thank you very much for all of you for being the part of this mission. Thank you. Thank you, Saranya, for giving me this opportunity.
Thank you, sir, for those wonderful and encouraging words. Truly inspirational. Now we'll move on to the next part of the session. So the way that we have organized the session is that we will take you through all the steps of the course.
Saranya,
Um,
can we ask Dr. Amit Upadhyay, Dr. Amit, to say a few words before we move to the
Sure.
Amit, please.
Isab, as you have explained it quite well, this session is just a revision course, and so that everybody does a standardized training at their all the coordinators should ensure that everything which is needed, you get all those papers, you print them for everybody, and the method of teaching is standardized across all the centers. And this online course is just it's not a training as such, but it is just ensuring that everybody remembers all the steps and helps us keep the standardized pattern of training everywhere. Thank you.
Thank you. Thank you, Amit. Thank you very much.
So moving on, thank you,
What would
sir, for
first
those
session, yeah.
words. Thank you. Moving on, we have the next part of the session, which is we're going to be discussing Skill Station 1, which is preparation for birth. And this will be handled by Dr. Vikas Goel. Over to you, sir.
Thank you, Sharanya. So, good evening to all of you. The first session of this training is preparation for birth. The time for this session is 30 minutes. So, in the next few minutes, I will discuss what to do and how to conduct this session. So, when we are talking about preparation for birth, there are two aspects of preparation. First is anticipation and planning. And the second important part is preparation of personnel, equipment, and supplies required for resuscitation. So first, I will discuss how we should anticipate and plan. As our president rightly said, that anticipation is the key. If you will anticipate and prepare, then only you will success. Otherwise, you are prepared for failure. If we are not prepared for success, then we are prepared for failure. So anticipation is the key. So whenever you get a call on for a labor room delivery, then there are certain things that you should do. First is you should anticipate what is going to happen. So you have to ask what are the risk factors. Now there are two type of risk factors. One is the risk factors which are in the antenatal period of life till conception to the delivery point. And then second is what are the risk factors which happen after the patient get admitted in the hospital, that is during labor. So we have to ask about these two things. The first thing is anticipation. So now the risk factors I will briefly outline. You should ask all the participants to inquire about these risk factors every time when they go into a delivery room. So the major antenatal risk factors are whether the baby is preterm or post-term. First is if it is preterm, less than 37 weeks. If it is more than 41, then it is an disturbance. Second is there any hypertension in the mother or eclampsia or pre-eclampsia diagnosis in the mother? Then the baby is high risk. Then whether there is a single pregnancy or multiple gestation, twins, triplets, then it is a risk factor. Whether there is, if any ultrasound has been done, whether it shows any poly or oligohydramnios or IUGR, then it becomes a risk factor. Is there any significant fetal malformation? Or suppose if a parent, if a mother comes with no antenatal care, kahin bhi nahi dikhaya, never shown to any doctor, then also it is an risk factors. So these are the major antenatal risk factors. Now we are coming to the intrapartum risk factors. It means the risk started after the patient got admitted in our hospital in labor. So what are the risk factors? The most important is, suppose most important risk factor for doing LSCS is that there is fetal bradycardia or fetal distress. If there is fetal distress, it is a risk factor. Then for any cause, if there is an emergency cesarean is being done, then it is a risk factor. Third is Any use of instrument for the delivery or vacuum for the delivery, it is a risk factor. Any presentation other than vertex, suppose it is breech, hands first, or transverse line, then it is a risk factor. Then suppose if there is a significant intrapartum bleeding during labor, the patient is come bleeding, then it is a risk factor. If meconium is present, it is a risk factor. If any placental abruptio placenta you are suspecting, then it is a risk factor. And also, if you are giving magnesium or general anesthesia to a patient, then it becomes a risk factor. So this is how you will inquire. Whenever you go for a delivery call, you will inquire about these risk factors briefly. Antenatal risk factors you can see in the file of the patient, and intrapartum risk factors, briefly ask about the risk factors which are available. Now, what will happen if risk factors are present? If risk factors are present, then you have to be alert that something the baby might require resuscitation. So this is the first step. If any risk factor is present, you become alert. Second point is you should call for help. Call anybody who is available in your hospital who can help you. He or she can be trained in basic NRP. If he or she is not trained in basic NRP also, then also you can call him to help in certain things. Second thing is, do you have any personnel available in your facility who can do advanced NRP skills? If yes, then please call that person. Suppose if there is nobody available or nobody can call in your hospital, then where you are shifting these type of babies. Earlier also these type of babies has been delivering in your hospital. Where are you shifting this baby? Call that particular hospital and tell the personnel over there that we are going for a delivery and it is a high risk delivery. The baby may require admission or advanced technique. So be prepared. Is their bed empty? Warmer खाली है या नहीं है? ये पूछना जरूरी है. Then the last point is, how will you shift this baby from your facility to that particular facility? That is very important. You should check whether you are shifting it from ambulance or from some private vehicle. Then you should check whether it is available or not. Second thing is, who will accompany the baby? Because you yourself should accompany that baby to that facility. Suppose the baby is not breathing, you are ventilating, then you have to go with the baby, ventilating the baby. Third point is, how will you maintain the temperature of that baby while shifting? It is very important. So if suppose a baby is preterm, breathing on itself, but we have to shift it to another place, then the temperature maintenance is very important. So what you can do is, either you can do shift the baby into transport incubator. If it is not available, then you can shift the baby on skin to skin contact with any family members or relatives of that baby. Or if it is going with private vehicle, give instructions that the AC should not be on in the car or vehicle, and a heater is available in every vehicle, private vehicle. So they should start the heater and keep the temperature of the car warm. So these are the important points in anticipation and planning. Remember, anticipation and planning is the crux of preparation. Now the second step is preparation of personnel, equipments and supplies required for resuscitation at your center. Now I will ask Dr. Prakash to please start that video. So all of you see that video, see this video, and in this video you will be shown how to prepare for personnel, equipment and supplies. Dr. Prakash.
Can I share the video, sir?
Yeah, you shared the video.
Yeah, I'm sharing from the delivery room preparation.
Yeah.
Preparing the delivery room and your equipment.
The sound audible?
The first step is to prepare the environment to keep the newborn warm. First, close the windows. This prevents cold drafts from entering into the room. Second, close the curtains. This will help in maintaining room temperature and provides privacy. Third, switch off the fans. Even a ceiling fan can create air currents that rapidly cool a wet newborn. Turn it off before the delivery. Fourth, switch on the radiant warmer. Turn it on at least 15 minutes prior to the expected delivery so that the warming surface is ready to receive the baby. Now, let us move to the next critical step, that is hand hygiene. Turn on the water, wet your hands completely under running water. Apply adequate quantity of soap onto your hands. Rub your palms together. Now rub the back of each hand with the opposite palm. Interlace your fingers to clean between them. Clean the backs of your fingers by rubbing them against your opposite palm with your fingers locked. Use your right palm to clean your left thumb in a rotating motion. Repeat for the right thumb with your left palm. Rub your fingertips against your palm in a circular motion to clean under your nails. Do this for both the hands. Rinse your hands thoroughly under running water. Ensure all the soap is washed off. Dry your hands with clean towel. The entire process should take at least 40 to 60 seconds. After hand washing, wear your gloves. While preparing equipment, first you need at least 2 warm, dry towels to receive the baby, extra pair of gloves, suction apparatus, cord clamp, cotton balls and gauze pieces, scissors for cutting the cord, vitamin K injection syringes, ventilation device with proper reservoir and oxygen tubing, masks for ventilation, both sizes, preterm as well as term, stethoscope for oscillating heart rate, shoulder roll. If you are using wall suction apparatus, make sure the pressure is not beyond 80 to 100 mm of Hg. Ensure there is working oxygen source. For bag and mask ventilation, we need appropriate size face masks, that is both preterm and term. Attach the masks to the bag in a screwing motion. To check whether the bag is functioning properly or not, see whether bag is getting recoiled back after squeezing. Next, whether you can feel the gush of air coming onto your hand while you are squeezing the bag. Now hold the mask against your palm and squeeze the bag and check for the pop of valve, whether you are able to hear the hissing sound or not. So, to summarize the learning points from this video, before every delivery, anticipate the risk. Review the maternal history, note down the antenatal or intrapartum risk factors if there are any, and prepare the team accordingly. Prepare the environment, that is, close the windows, curtains, switch on the radiant warmer. Maintain hand hygiene, wash your hands thoroughly, prepare the equipment, and be ready for receiving the baby.
Yeah. Prakash, now as you all have seen this video, so now what is important? As an instructor, you will get only 30 minutes for this session. So what is important is when you will start this program, this training, first you will demonstrate all the things which are shown in this video. And as I have told you how to anticipate and plan, and then you will show how to prepare for personal equipment and supplies. Second thing is when you are showing, the two important points here are how to wash your hands and how to check the bag and mask. So what you will do is let all the participants imitate you when you are doing the hand washing. Tell them to show how you will wash hands. So all the participant in group will show you hand washing, and let all the participants show you how to check bag and mask. Third thing is, because the time is very less, it will already consume 15-20 minutes of you. So now what you can do is you can make one or two people do this preparation, show you the how to prepare for birth. So make a team of 2-3 person. One person will become a gynecologist. One person will become the healthcare worker who is going for NRP, and one can become helper. And they can show how they see how they communicate with gynec regarding asking about the risk factors, and after asking the risk factors, what they are doing. So I suggest you should make two scenarios. In one scenario, you should give that a baby is a preterm baby, 28-weeker baby, and delivery is going to happen. Then see how they anticipate and plan. Second is, you can give a case where the baby is having fetal bradycardia, full-term baby, but the baby is severe distress, fetal distress, and forceps delivery is going to happen. Then how they prepare, how they anticipate, how they plan and prepare. So not more than two persons will be able to do this, but make sure that every participant, all 10 of your participants, show you how to wash their hands, and second, how to check bag and mask, and third, there is no you should not remember all the
Sir, 5 minutes
equipments.
left.
Yeah, you should not know how all the equipments, and you should have a checklist posted in your labor room where you can see and check whether all the equipment and things are present or not. So this is from my side. So now we will go to, if there are any questions. Brijender, is there any questions regarding this session? So I can answer in a few minutes.
Sir, one question only.
Yeah.
Dr. Lingaredi asked about the embrace for safety. Do you recommend?
What?
Sir, embrace.
Embrace,
Embrace.
embrace, sir.
Embrace. Yeah. Embrace for transportation. Na? Yeah.
Yes, sir.
Yeah, we recommend that thing. So I have already told, if any incubator, embrace, or skin to skin contact, whatever facility is available, just ask the participant what is the facility available at your place, and then act accordingly. Some, because we are talking pan India, there are different type of facilities available at different parts of time. So we have to accommodate according to, we have to adapt according to the facilities available at your center. So no baby should, every baby should be given the advantage of everything, every knowledge which we have. Suppose there is no equipment, then also we can do something. So this is only the method how you anticipate and plan and do better. This is our plan. So now I will ask Charanya to go over to our next session, which is initial steps in routine care by Dr. Prakash.
Thank you, sir. Thank you for that session.
Sir,
Now we move to
remaining
the
question we will remaining question we will take into in last, no?
Yeah, we can, Vijendra, we can take the question later on also. Let the
Okay.
class start.
Okay.
we will move on to the next session
Yeah,
by Prakash, sir.
thank you. Thank you for the invite. So this session will we'll cover two stations. One is the preparation of, birth of a baby who is crying and where we provide routine care. The second one is when after drying, baby is still not breathing, and what would be the initial steps for the baby to cry. So all what we want you to understand is here in this session, one request is that please stick on to the protocol. What is shown in the video. Do not deviate, because this is a basic NRP program where we understand there are not going to be very high risk deliveries going to happen. This is for a common scenarios where baby is not going to require, they're not be very complicated scenarios. We're just going to teach them how to provide positive pressure ventilation at the end. Now in this two sessions, the first session is this will be your second station in your workshop, where we talk to them regarding what will you do when the baby is, crying after birth. So important things to cover here is, we know baby is in a very warm environment. It is now coming out, will be very cold. So first thing we'll take care will be the warmth of the baby. So you just dry the baby, and then suction we discourage at this point of time. There's no suctioning, even there is meconium stain like that. And then put the baby onto the mother's abdomen immediately. The next thing we do is here is that we warm and remove the linen, maintain temperature. Second is umbilical cord clamping, delayed deferred or delayed umbilical cord clamping, which should be done after 1 to 3 minutes. And then we immediately encourage the baby to be put on breastfeeding, cover the baby again, and then tell the mother regard the baby and tell what she should be looking for. And then, at the end of it, we also give vitamin K injection, right? So this is about, what you will see in routine care, and that is what will be seen in your video also. And please don't confuse with the advanced NRP training. There's a little bit of change between this and that. You need to change mode. This is adapted to to a primary care level. So I'll play the video of the routine care, and followed by we will see initial steps.
In this video, we will learn about what to do immediately after birth and how to provide routine care for the baby. Once the baby is delivered, note the time of birth. Time of birth is 5:08 p.m. Receive the baby in dry linen. Place the baby over mother's abdomen.
So this will be a pre-warmed linen, where you would have kept it during the preparation under the warmer.
Head of the baby to one side. If there are any visible secretions, wipe the mouth and nose.
So here, for the instructors to understand, please, as far as possible, do not turn the baby's mannequin or head. Just tell them that it should be moved, but do not, this is a video demonstration that is shown like that, because the mannequin will actually get spoiled. So do not turn the head too roughly. The joints will break and it will damage the mannequin. Please do it very softly.
Dry the baby thoroughly. Remove the wet linen. Observe for the baby's breathing. Yes, baby's
So
breathing.
in this station, what we do is we call upon volunteers and try to, imitate this on the, abdomen. On the, you put the baby on to the, abdomen, and on the mannequin onto the, make someone sit on the chair and, inform them, and then put on the abdomen to demonstrate, to just see how it can be performed, rather than putting it on the table.
Well, as baby is breathing well, we can continue routine care for the baby. We can continue skin to skin care with the mother, and cover the baby and mother with dry and warm linen. Clamp and cut the cord after 1 to 3 minutes. Place the baby over mother's chest and explain the mother about the baby's condition and start breastfeeding for the baby. To summarize the learning points from this video, once the baby is born, note the time of birth immediately. Receive the baby in a dry and warm linen and place the baby over mother's abdomen in prone position. Turn the head of the baby to one side. Wipe the secretions if there are any visible secretions. Dry the baby thoroughly and remove the wet linen. Now assess for the breathing of the baby. If the baby is breathing well, we can continue routine care for the baby, which includes skin to skin contact with the mother, clamp and cut the cord after 1 to 3 minutes, start breastfeeding for the baby, and monitor the baby for breathing and color with the mother.
So that's come to the end of the birth and routine care. So what you need to remember is, baby skin to skin contact, which is very important. In many places still they do not do it, and we need to encourage them to do that. Skin to skin contact, drying the baby and maintaining the temperature. And then next is, delayed, cord clamping, breastfeeding. And of course, the video missed out on vitamin K injection. Vitamin K injection should be given. Okay, that also needs to be insisted on. So next is like now what we do is we take it like a story. The next station, what you do is you tell them, you start the station telling that so far what if the baby cries, what you should be doing. Now let us see a baby who does not cry at birth and what should be done. Now remember, crying is assessed only after drying, unlike advanced NRP. Here, crying is assessed only after drying. Baby, drying is done, removed wet linen, and then only they assess for breathing. Please do not, assess, get confused between the advanced NRP and basic NRP. So
Prakash,
in this also, it is like similar. You try to, do things on the mother's abdomen. I think there is one extra. I don't know why that is coming. It's not
Prakash,
seen
that
on my
black band
screen,
is
but
coming. A black band is
are
coming.
you actually seeing?
Yeah, yeah. I am also seeing this black band.
How do I take it? There is not seen in my screen. Okay,
Acha,
let me stop and share again.
yeah.
Yes, it is
Because
coming. Yeah,
now you stop and share again.
share.
No, we can see nothing.
Yes, 1 minute. I'm just correcting it.
Yeah.
1 minute.
Just start. Yeah. Now it's good.
It's good. Okay, sir. Thank you.
Yeah. Just start.
Sorry for that interruption. Right. So now here in initial steps, what we're going to say is now we have tell them that so far we know what to do in a baby who was breathing. Now let us see even after drying, if the baby doesn't breathe, what should be done to facilitate breathing. So that will be the objective of this station. So once a baby breathes after initial steps, then the rest all the steps are almost same as routine care. So what they do in this also baby till baby is drying, there's no change. They receive the baby, put on to skin care, and then dry the baby and remove the wet linen, and again put the baby on they assess the baby for breathing. Now, if the baby does not breathe, then here it is different from the protocol of the this thing there. Here then we clamp and then shift the baby to the warmer. Then we do something called PSSR. That is, we do position, suction, stimulation and reposition. When you stimulate, you're going to change the position of the baby, so you need to reposition. And then you need to, in this time, you need to take care of the, shoulder roll, align the airway, make the air open to open the airway. And then once this is done, and then, once the baby starts breathing, then you assess baby, is the baby breathing well to, sure that baby is going to be, which can be safe enough to be shifted back to the mother. And we initiate breastfeeding and again tell them that the, mother to, observe the baby even more intensively. And, on every 15 minutes for the first 1 hour and then 30 minutes after in the second hour. Okay, so we will see the video, the same thing which will be demonstrated in the video. Thank you.
In this video, we will learn birth and initial steps. Once the baby is delivered, note the time of birth. Time of birth is 5:08 p.m. Receive the baby in dry linen. Place the baby over mother's abdomen. Turn the head of the baby to one side. If there are any visible secretions, wipe the mouth and nose. Dry the baby thoroughly. Remove the wet linen. Observe for the baby's breathing. If the baby is not breathing, clamp and cut the cord immediately. And shift the baby to radiant warmer for performing initial steps. If the baby is not breathing after birth, we shall proceed to initial steps. In the initial steps, first we shall place the baby over radiant warmer. In initial steps, the first step is to keep the baby in proper position, that is sniffing position, in which the head and neck should be in line. So for which we can use a shoulder roll. Now we shall stimulate the baby by gently rubbing over the back couple of times. And in stimulation, we shall avoid vigorous rubbing or slapping over the back and shaking the baby. Now reposition the head and neck. If there are visible secretions are present, we shall do suction of the mouth first, followed by nose. So when using suction catheter, precaution should be taken that it should not go beyond 5 centimeters into the mouth and next 2 centimeters into the nose. And one more precaution we should to take while doing suction is avoid vigorous suction, and which will injure the mucosa and it can cause bradycardia. If you are using suction catheter with a wall suction machine, the pressure should be between 80 to 100 mm of Hg. After initial steps, we have to assess for the breathing of the baby. If the baby is breathing well, we shall shift the baby to observational care. If the baby is not breathing after performing initial steps, we shall proceed with bag and mask ventilation. If the baby is breathing after these initial steps, the baby should be kept in observational care with the
Before that, how do you know, how do the participants know the baby is breathing well? So they should have the baby should be breathing at the rate of about 30 to 60 breaths per minute. There should not be any retractions or grunting, and then the baby should have both sides of the chest should move equally. So if they observe these three, then they label this as breathing well. And they have to count for 1 minute.
mother. During the observational care, place the baby on mother's chest. Cover the baby and mother together with a warm cloth and initiate breastfeeding. Along with this, we need to monitor the neonate for temperature, heart rate, breathing and color every 15 minutes during the first 1 hour and then every 30 minutes in the next 1 hour. Now, we shall summarize the learning points from this video. Immediately after the birth, note the time of birth, receive the baby in a warm towel, place the baby over mother's abdomen, turn the head of the baby to one side, wipe the secretions if any visible secretions, dry thoroughly and remove the wet linen, assess for the breathing of the baby. If the baby is not breathing, clamp and cut the cord and shift the baby to the radiant warmer for performing initial steps. The first initial step is position the baby, followed by stimulation of the baby, next reposition of the baby and suction of the secretions if there are any visible secretions. If the baby is breathing after initial steps, shift the baby to the mother for observational care. If the baby is not breathing after initial steps, start bag and mask ventilation for the baby.
So in that, you could use the initial steps as, as I told you that PSSR can also be used or what has been told. So the sequence of the steps are not very strict. They have to do only this way. But remember that they should do all this, position the baby, they should clear airway by suctioning, stimulate the baby, and then reposition so that, the airway is, open. So that is what you need to understand. So don't get too this thing about, is a step PSSR or is it first stimulation and then suction? And they have to understand that these all things needs to be done. Right. Okay. So I think this comes to the conclusion of my the session on if the baby who breathes, routine care provided and initial steps. And remember, vitamin K should be given. That also should be insisted. So with that, I stop my this thing. If there are any questions, probably I'll be happy to.
So, Brijender, is there any question?
Sir, no, sir. All questions are answered by sir and ma'am in written answer. In the answer in text message.
Do we have time for 2-3 questions? We can have some on the chat box.
So, Prakash, are you going to take the
Shoulder roll?
Yes, sir,
Shoulder roll is not
recent.
mandatory. If you feel the baby's airway is open without the shoulder roll, you don't need. It will be definitely needed in a baby who is preterm and very severe IUGR, where occiput will be very prominent. So that you need to teach them how what is that sniffing position is.
Sir, 3 new questions are there. Sir, can we take?
Yeah, I think we can take Brijender.
Vernix has to be removed or not? Dr. Malish Godwa.
Is not able to maintain, or if there is neck flexion.
It is about
Vernix should not be removed.
Vernix.
Some other question is the pulse oximeter.
First,
No, we are not demonstrating pulse oximeter in this NSSK. Please change your mode from advanced NRP to basic NRP. In basic NRP, we understand with basic I'm designing this. Sir has also answered some of the questions. Yeah, anything else? Yeah, please.
Sir, next question is, sir, why we should avoid vigorous stimulation while rubbing back of the baby? Dr. Sachin Kumar.
Why we should avoid rigorous stimulation?
Yes, sir.
Okay. Now remember the best stimulation which will stimulate breathing is the tactile stimulation. The tactile stimulation is just touching and comes under tactile, touching and rubbing. Vigorous will actually put the pressure or pain, and that will actually can induce apnea again, can actually reduce the chances of breathing. So definitely don't do rigorous, anything vigorous on a neonate.
So next question is cap must for the temperature maintenance?
Yes, cap is a must.
Next question is
As soon
sequence.
as baby is dried, you have to put on the cap. Even if the baby is on skin to skin care.
Next question is, sequence should not be strict, but can not do stimulation before suction.
Yeah, that's what I told you. I'm not sure that is they need to really follow that sequence. You can tell them that these are things they should do. At the end of it, they should understand that they need to position to open the airway, and then they need to clear airway, because airway should be clear for the baby to breathe, and then they should stimulate. Because you're stimulating, you would have changed the position, so you need to reposition.
Sir, next question, when to
In
reveal.
the position itself, you should talk about shoulder roll.
Sir, next question, when to reveal gender of the baby.
Yeah, I think that can be unit protocol. It is not part of the NSSK or basic NRP. I think you can have your unit protocol whenever the baby is fine, and at least we should put the baby on the breast, and then skin to skin contact should be given for 1 hour after birth.
Sir, one request from Dr. BD. Please send the video for the showing in the class and for uniformity in all center. Sir, so we already sent video
available with all of them.
Yes,
right?
Sir. Sir, Dr. Nupur Pandey asking for the sir, please tell mode of the warmer.
Yeah. Okay. Warmer mode is like usually there is 2 types. if the warmer which you're using is a resuscitation warmer, which if it has a pre-warm mode, you just have to switch on about 20 to 30 minutes before, put on pre-warm mode. What it does is it will start with 100% and starts coming down, and it will stop at around 20 to 30% of heater output and will remain there. This is to
Yeah.
avoid hyperthermia.
Yeah. Prakash,
Now, in case if you are not,
the ventilators, most of them have a manual mode. Manual mode. So
yes, sir, that's
we
what I'm
use,
coming
yes.
to that, sir.
Yeah.
Now, in case if you're not having a pre-warm mode, then you put the baby in, put the warmer in manual mode and put the heater output to 100%. And then based on the, this thing, heat generated there, then you can control. Once a baby comes, you connect the thermistor to the baby, and then you can move to a servo mode.
Sir, one next question, Dr. Malesh
That's
Kodwa,
a very good
about
question that
stomach was.
somebody raised. Thank you for raising that.
Sir, about stomach was required or not?
No stomach wash. Even in a Micronstein Liker, we do not do stomach wash. We don't teach rails tube, this thing here, insertion also here.
Sir, Avesh Pani asking about how to do steps in LSCS delivery.
Right. Now, the recommendation even in LSCS also, it is skin to skin care, delayed cord clamping and all that. But then you have to, talk to the anesthetist and your obstetrician to convince them. So if they ask that whether in LSCS, is it feasible? It is definitely feasible. So many centers do that. So you need to, put the baby on skin to skin care between in the umbilical cord length is good enough to be pushed, put the baby onto the abdomen, onto the chest, and then we can actually delay the cord clamping and then put the baby on breastfeeding.
Sir, next question by Dr.
And
Priyanka
then you
Verma.
delay.
If there is no activity, no breathing in child, should we check heart rate with the stethoscope before doing initial steps?
Okay. Now remember, this program is designed for in a facility where the resource is very poor and people do not have a very trained hands, and we are trying to do the best possible. So here, whatever the baby's condition is, even in advanced NRP, we don't have to look at the heart rate. If the baby is not breathing, the earliest time we should initiate positive pressure ventilation is what is recommended, even in advanced NRP. Only if you are having another person in hand, then only you go and check the heart rate. So don't give importance to heart rate, even if the baby is totally flat. Yeah, you just deliver the baby onto the abdomen, dry the baby, and in that will also be stimulating the baby, still not breathing, clamp and then shift the baby to the warmer. Please keep this uniformly, taught to them. Do not complicate too much, to ask them to look at the heart rate. So in this, module, we just only teach them. They put the protocol is same for all babies. However, they are born, they are totally floppy also. The baby is taken, put onto skin to skin care, dry the baby, remove the wet linen, then they put cover with a dry, wet, warm linen again, and then they assess for breathing. And if the baby is not breathing, then the baby is the cord is clamped, inform the mother, and shift the baby to the warmer.
Sir, one query for management, like all skill station per table happens with same instructor or we rotate in groups?
Okay, the instructor only will rotate. The participants do not rotate. Participants will stick on to the table from the first station till the end of the session.
Prakash.
Now, I would like to clarify for all the instructors, the one case scenario 28 weeker, please avoid, because this time the line we have given is mainly to cover the baby, to provide routine care, and a baby who is needing resuscitation of a late preterm and term baby. The baby less than 28 weeks delivery, they should really look into other programs, or I'm sure there should be a pediatrician is available who will be able to take care of advanced care. But here we
Prakash.
don't teach them to keep the plastic wrap ready.
Yeah. Prakash, only one thing I want to add, that regarding the rotation. So for the rotation, what we have made, since the preparation for birth and initial care and routine care are 30 minutes workstation, so we will first rotation will be done after initial routine and initial care. So for first 30 minutes and 30 minutes, after first hour we will rotate first. Okay, not after, because it will disrupt all the things. So all of you remember that the first rotation has to be done after the completion of routine care and initial steps. Second rotation has to be done after the ventilation, and third rotation will be done after that. So that I will also explain in the last session. So for this time, you should remember that the first rotation will be done after preparation and doing routine care and initial steps. Also remember, the time for routine care and initial steps is only 30 minutes. So as an instructor, you will first demonstrate how to do routine care and initial steps. Not everybody will be able to do both the PCL 2 and 3. So what you will do is, few people will do routine care and some will do initial steps. Okay.
Yes, sir.
So
So I think, Saranya, now
because
to move to the next.
we have a time constant. In this anything,
Yes,
as
sir.
you go to the second stage, you will demonstrate.
Yes. So
Yeah.
I would invite,
Thank you.
no, next, now we have seen the baby. Oh, sorry. Yeah, Dr. Shania, please go on.
Sir, hope you're done, sir. Prakash, sir, can I move on?
Yeah, please.
Okay. Thank you, sir, for that really clear session. I think a lot of questions were also answered, but we'll take the rest of the questions at the end of the session. The only thing that I want to stress on is, like Dr. Vikas was mentioning, the rotation of the tables. So I hope everybody is clear about when to rotate. So the participants stay at the table and the faculty rotates. And the other most important thing is use of PCLs at every station. So the PCLs have been shared in the participants folder as well as in the course coordinator folder. PCLs are the performance checklists, which are for each station. So they are designed for that particular station. And we do not want to talk too much about theory. It's not theoretical. It's going to be very practical, hands-on. So we should make a either note down or a mental picture of what are the salient points that we are going to discuss. What are the most important points that should not be missed at every station? And the PCL has to be performed because we have 10 participants at each table. Generally, we insist that every participant does the PCL, but because we have 10 in each table, we can also design it in such a way that 5 people do one part of the PCL and the other 5 do the other part of the PCL. So for example, 5 can do routine care and 5 can do initial steps. So, it can be done so that everybody gets well versed with doing hands-on. So it's not going to be lecture-based teaching. It is going to be more hands-on. Like Vikas sir was mentioning, even showing the baby being put on the mother's abdomen has to be demonstrated. Has to be demonstrated with a volunteer or a participant on a chair. Now we move on to the next part of this evening session, which will be taken by Dr. Akash. This is on PPV. Over to you, Akash.
Am I audible? Saranya?
Yes, please.
Yeah. Okay.
Proceed.
Okay. Thank you so much. Thank you, everyone. And thanks, Saranya, for inviting me. Before we go ahead, I just wanted to remind the participants of this meeting something that wrote in the chat box also. We have to remember that this session has 2 aims. Okay, the first aim is to revise the algorithm, the NNF, the NRP algorithm, basic NRP algorithm. So that is the science part of it. Most of us know that, and we are just kind of revising, making a quick revision. The second important aim of today's session is to help all of you who are going to be instructors on 10th May, to help all of you plan your teaching sessions. So it is important that all of us start planning our sessions mentally, so we are ready with kind of a lesson plan how we are going to conduct each session when we go as instructor on 10th. So the next segment, as you know, the next PCL talks about brief ventilation. So here, one of the most important thing in the whole workshop is the skill of ventilation, the actual skill of ventilation. And if you look at the agenda, you will realize that there is around 75 minutes devoted for PCL 4, 5 and 6. PCL 4 is brief ventilation, which is first 30 seconds of ventilation. PCL 5 and 6 is prolonged ventilation with normal and slow heart rate. So how are you going to teach this skill in 75 minutes? So roughly 45 to 60 minutes should be devoted to first part, brief ventilation part, because that is the part where you are actually going to talk about the skills of ventilation and the corrective steps, and remaining 15 to 30 seconds. So around total 75 minutes you will have to divide mentally like this. Please do not spend too much of time in, I would say don't spend time at all in discussing theory, because we will have 10 participants for each faculty, and we will have to ensure that, so unlike preparation where we can skip, we can make 1 or 2 people demonstrate the whole preparation part and then skip for others. Unlike that, for ventilation, we need to ensure that each and every single participant out of those 10 have been able to show the correct ventilation technique, the correct use of corrective action and all those things. So here don't spend any time in teaching, let's say, parts of the back, or no need to even repeat the scenario starting from birth, drying, initial steps, no need to do that. So we can directly start by saying that, okay, a baby was born, he was dried on mother's abdomen and baby was still not breathing, so baby's cord was cut and baby was shifted to radiant warmer. Here the initial steps were given and still the baby is not breathing. So we start the scenario from there. That what that does is that gives them an idea where this particular segment of ventilation is in the big picture of algorithm. So it is kind of talking about indication. So we start with that. And as Dr. Vikas said, for not only for this, but for each segment, you have to first demonstrate. So you first demonstrate and then quickly make each one of them practice. Okay. So we'll see the video, but before that, let us just go through the ventilation scenario. So in the brief ventilation, you will start by saying that, okay, this baby is still not breathing after initial steps. So what should we do? So we should give ventilation to this baby. So where to stand? So talk about where to stand, how to choose the correct size of mask. So explain that. You can talk about which hand the bag should be held in. So we usually say that dominant hand, right-handed person should hold the bag in right hand. How to apply mask on the bag? So mask application, you will have to show that putting the thumb inside the mask, putting 2 fingers like this, and then screwing motion say mask to be applied to the bag. Then how to hold the mask on the face using the EC. So you with your 2 fingers making a C like this, you will be facing the mask on the baby's face. You will be pressing the mask on the baby's face, and using the other 3 fingers you will be realigning the position, and then start ventilation by giving breath 2, 3, breath 2, 3. Now here, so each of these skills is important because some of the participants will be doing this for the first time in life. So talk about this breath 2, 3. So explain to them that it has to be done like breath 2, 3, breath 2, 3. So explain to them that breath 2, 3, breath 2, 3. This is not the correct technique. Or using the rhythm, like instead of using the rhythm breath 2, 3, saying breath 2, 3, breath 2, 3. This is not a correct method. So like this, you can explain how to use the rhythm breath 2, 3. Then tell them that after you start ventilation, within few breaths, within first 5 breaths, we have to look for the chest rise. So here, unlike advanced NRP, we need to, most of the participants will be doing this for the first time, but most of the instructors would already be tuned to advanced NRP. So it is very important to switch to the basic NRP mode. And so understand that here the effectivity of ventilation in basic NRP is judged by chest rise checked within first 5 breaths. So look for chest rise. If there is no chest rise seen in first 5 breaths, then we go for corrective steps. If chest rise is visible, then we don't even need to wait for 5 breaths. We don't need to waste time. If chest rise is visible within 1 or 2 breaths, we start doing 30 seconds of positive pressure ventilation. If the chest rise is not visible in first 5 breaths, then we go for corrective steps. Corrective steps include M and R, which is mask reapplication and reposition of the neck done together, and then again tried few breaths. Then again, if chest rise is not there, then suction and increase the pressure. So MR, then few breaths, then SP if chest rise is not there. Whenever good chest rise is there, from there 30 seconds of ventilation starts. Again, explain to them that it is not that as if you have got chest rise in the beginning, that ensures that chest rise is there throughout the ventilation. So explain to them, emphasize to them that chest rise should be carefully monitored throughout the 30 seconds of ventilation. So you start doing breath 2-3, breath 2-3, breath 2-3 for 30 seconds. During these 30 seconds, you are monitoring for chest rise. One common mistake that we do as instructors is when a participant has got a good chest rise, just to make them verbalize the MRSP, we say that no, there is no chest rise. Now this demotivates learners. So if someone by on their own, by default, if someone has got good chest rise, then applaud them and don't talk about corrective steps there. You can say that very good, you have got a good chest rise. What if there was no chest rise? Then what you would have done? That you can ask. But otherwise, the basic aim is that everyone should be able to get a good chest rise. If they are not getting, then they should be able to do these corrective steps. They should be able to manipulate so that they get good chest rise. So that is the basic aim. If someone has got that, don't interrupt them. Another important thing here is to make everyone do actual ventilation for actual 30 seconds. So we don't want to cut down ventilation. Let's say after 10 seconds they will say 30 seconds is over. That is not done. So let them actually do, let each participant demonstrate effective ventilation with good chest rise for full 30 seconds. So that is how each one of them should be required to demonstrate to you. Then towards the end of the 30 seconds, the question that we ask is, are spontaneous breathing efforts present? If spontaneous breathing efforts are present, then we slowly taper off. So that you can do, people use different methods. You can say breath 2, 3, 4, breath 2, 3, 4, 5, breath 2, 3, 4, 5, 6, like that you can taper off. After tapering off, now remember till now we were giving ventilation. Now we have tapered off. Now we have to observe the baby's spontaneous breathing. So after tapering off and stopping the positive pressure ventilation, now we will observe the baby for around 1 minute. And now during this 1 minute, we will observe the baby's spontaneous breathing rate. Also whether there is any grunt, there are any retractions, all these things we will observe. And if the baby is breathing well, then this baby goes for observational care. Observational care has already been discussed. Okay, so this concludes the 4th PCL, that is brief ventilation, that is ventilation for first 30 seconds. Okay, now so as I said, this you should devote around 45 to 50 or at the most 60 minutes for this brief ventilation part. Last 15 to 20-30 minutes should be devoted for prolonged ventilation. So what is prolonged ventilation? So after 30 seconds of ventilation, if the baby is still not breathing, then what to do? Then that we continue ventilation, that becomes prolonged ventilation. So let us watch the video on brief ventilation first, discuss that, and then we go on to prolonged ventilation. So Prakash, you can show the brief ventilation video number 5.
Shall I play the video?
Yes. Brief ventilation wala video.
Yeah.
Ventilating the baby's lungs using a bag and mask represents the most critical intervention in neonatal resuscitation. In this video, we will demonstrate the proper technique and sequence for bag and mask ventilation. If the baby fails to breathe after you complete the initial steps, begin bag and mask ventilation immediately. So for performing bag and mask ventilation, one can be placed at the head end of the baby so that you can have unintended access to the chest, which will help us in checking the chest rise, whether we are doing effective ventilation or not. So while performing bag and mask ventilation, the most important thing is to select the appropriate size mask. For preterm babies, we can use preterm mask, that is 0 size, and for term babies we can use term mask, that is 1 size. So this mask should be applied firmly to the bag. So while applying the mask onto the face, make sure the mask covers the chin, mouth and nose, and we have to take the precaution that the mask should not come onto the eyes. Whenever we are doing bag and mask ventilation, when we need to place the mask onto the baby's face with C and E technique. C is by using thumb and index finger, we shall encircle the mask onto the baby's face, and with E is formed by 3 fingers. So these fingers will be used to extend the neck a bit so that airway is in line. So and we should not press the eye of the baby. At the same time, we should not press the airway, and the pressure required to inflate should be as minimum as possible, which can have minimal gentle chest rise. When we are doing bag and mask ventilation, we need to do ventilations at a rate of 40 to 60 breaths per minute. So this can be done by following the rhythm breathe 2 3, breathe 2 3. So we need to inflate when we say the term breathe, and we need to deflate or leave it when we say the terms 2 and 3. Breathe 2 3, breathe 2 3, breathe 2 3. Once we start bag and mask ventilation, we shall do 5 breaths. Breathe 2 3, breathe 2 3, breathe 2 3, breathe 2 3, and check for chest rise. If there is no chest rise, we need to do ventilation corrective steps. First, mask adjustment, then repositioning of the neck. Next, again we'll start ventilations. Breathe 2 3, breathe 2 3, breathe 2 3, breathe 2 3, breathe 2 3. After 5 breaths, we shall assess for chest rise. After 5 breaths, if there is no chest rise, then we shall do other ventilation corrective steps like suction, and then open the mouth, and we shall continue ventilations. Breathe 2 3, 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 breathe 2 3. After 5 breaths, we shall again assess for the chest rise. If there is no chest rise, then we shall increase the pressure in the bag. Breathe 2 3, 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 breathe 2 3. Once chest rise is there, we need to continue ventilations for 30 seconds using the sequence breathe 2 3, 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 breathe 2 3. After 30 seconds of ventilation, we shall assess baby's breathing. If the baby is breathing well, we shall slowly stop ventilations using the sequence breathe 2 3 4, breathe 2 3 4 5, breathe 2 3 4 5 6, breathe 2 3 4 5 6 7. Then we can stop the ventilations and we can shift the baby to observational care. If the baby is breathing after these initial steps, the baby should be kept in observational care with the mother. During the observational care, place the baby on mother's chest, cover the baby and mother together with a warm cloth and initiate breastfeeding. Along with this, we need to monitor the neonate for temperature, heart rate, breathing and color every 15 minutes during the first 1 hour and then every 30 minutes in the next 1 hour. Now we shall summarize the learning points from this video. Bag and mask ventilation is the most important and effective step in neonatal resuscitation. Always ensure clear airway before ventilation. Position yourself onto the head or to the side position so that you have clear view of the baby's chest. Mask sizes required are both preterm, that is size 0, and term, that is size 1. When you are applying the mask onto the baby's face, ensure you cover the chin, mouth and nose and not the eyes. Breathing rate is 40 to 60 breaths per minute. So the rhythm we need to use is breathe 2 3, breathe 2 3. After 30 seconds of effective bag and mask ventilation, assess for the breathing of the baby. If there is no adequate chest rise, we need to do ventilation corrective steps. These are adjustment of the mask, repositioning of the neck, suction of the oral cavity and nose, and opening the airway and increasing the pressure in the bag. Assess for breathing status after 30 seconds of effective bag and mask ventilation of the baby.
Okay, thank you. So if there are any questions in the chat box, we can take those questions right now. A few things here. So if just to summarize, what are the most important points of this particular PCR? One, ensuring that every participant is able to demonstrate how to do ventilation, how to hold the mask, how to give the ventilation, the rhythm, and to produce good chest rise. If there is no chest rise, every participant knows what to do. Okay, what are the corrective steps to be done? Every participant demonstrates to you actual full 30 seconds of TPV, and every participant knows how to end ventilation. So what to do after 30 seconds, that every participant is able to demonstrate. So these are 3 or 4 learning points of this particular segment. If there are any questions, I would like to take them. So I think first question I could read was that is there any specific time given for tapering of ventilation? No, there is no specific time. People give different ways. One common way that is told in basic NRP trainings is basically increasing the gap between 2 breaths. So instead of breath 2 3, you start saying breath 2 3 4, breath 2 3 4 5, breath 2 3 4 5 6, so that the gap between 2 breaths is slowly increasing, and then you stop. Any other questions?
Sir, for congenital anomaly, we have followed same procedure. This is a question from Kumar Chitra.
Yeah, so depending on the what is the congenital anomaly, for every baby who is not breathing after drying and initial steps, you would be attempting PPV first, right? Now, depending on the exact anomaly, that will become an advanced care scenario. So it will depend on what exactly anomaly is there, right?
Sir, next is just query. The
So
PT.
as I said, see, one important thing that I want to say is that, as I said, this is a basic NRP program, and the participants are going to be people who would probably have never had the chance to do bag and mask ventilation. We are teaching them this important skill. So basic focus of this particular session should be ensuring that every participant gets that skill. Okay, so rather than discussing theory or rather than discussing rare scenarios, it is important because time is also limited. So it is important that we focus on the skill transfer.
So
Pulse oximetry is not included in basic NRP. Yes, sir.
The PT need to be uploaded as well as the attendance sheet. This is query.
Sir,
And
all
should
the-
we also?
Sir, all the
Should we also
documentation.
require to send the hard copy?
Sir, all the documentation, organization, logistics related queries we can take at the end, towards end. Are there
Okay.
any queries related to brief ventilation segment?
In basic NRP, should we teach the participants to have someone to keep the timer? This is query from
Yeah,
Monica.
so timer should be there in the equipment. So one clock with second hand should be there in your equipment. However, if you carefully see, heart rate assessment has still not come. We have still not assessed baby's heart rate. In basic NRP, the heart rate assessment comes after 30 seconds of ventilation. I am going to talk about it. So just let us be clear about that. Secondly, we have still not attached oxygen. We are still ventilating with room air. The first 30 seconds ventilation is with room air. Third, there was a question, after 30 seconds baby goes to observational care or post resuscitation care. For basic NRP, please remember, babies needing less than 1 minute of ventilation, or you can also teach that babies who need brief ventilation. So brief ventilation wale babies will go for observational care. Prolonged ventilation wale babies will go for post resuscitation care.
So mask selection should be done prior while we are asking for risk factor or before ventilation.
Say it again, pardon. I didn't get it.
Sir, asking about the mask selection. Should we before when brief ventilation is starting, or ask about after before asking the risk factor?
No, definitely. Mask size determination has to be done before we start ventilation, right? We need a correct size mask. So that's what I said. Before ventilation, just talk of two important things: where to stand and which mask size is the correct size. Selection of appropriate size mask and your position.
Sir, can you explain how to open the mouth? Should we manipulate the tongue position with our finger?
Okay, so for the current basic NRP edition, open mouth, that particular corrective action has been removed. Okay, so we are teaching the government manual, the government module, and so we have to stick to these 4 corrective steps: MR, mask reapplication and reposition of neck, then few breaths, and then suction if needed, and pressure increase. So here there is no open mouth right now in this algorithm.
The protocol for the thick MSL and thin MSL, non-breathing baby.
So I think again we have come a long way now. So we are not considering any different management of a meconium stained liquor. The current recommendation, even for advanced NRP, is that meconium stained liquor doesn't change management. Management is same.
To hold the mask or apply the mask C and E technique to be demonstrated.
Yes, of course. So as I said, for every faculty will first demonstrate and then only ask the participants to practice or give demonstration. So for each segment, we first demonstrate and then ask each of the 10 participants to give reverse demonstration. Shall we go to the next segment? We can take the other questions later. There is a small video remaining. Okay. So yeah. So as I said, we discussed brief ventilation, which is the first 30 seconds of positive pressure ventilation. We discussed the scenario where within first 30 seconds baby starts spontaneously breathing, and we saw how we taper off the ventilation and how we send this baby for observational care after ensuring that the baby is breathing well. Now what to do if at the end of 30 seconds we note that there are no spontaneous breathing efforts. Now this baby of course needs continued ventilation. This is called as prolonged ventilation. So ventilation will continue happening, breath 2, 3, breath 2, 3. Now we will call for help. So there are 3 points you will teach. 3 points are: call for help, tell the helper to attach oxygen, okay, and count heart rate. These are the 3 points that you can tell the participants. You can also tell the formula HOD. Tell them that whenever there is a problem, we call HOD. So H stands for heart rate, O stands for oxygen, D stands for doctor, which means advanced care. So these 3 things we do, and we continue ventilation as it is. So we continue doing breath 2, 3, breath 2, 3 for 30 seconds. Now only difference is every 30 seconds we will keep on checking heart rate. because further management will depend on heart rate. When the heart rate is found to be slow, which is less than 100, this baby needs advanced care urgently. So we will have to get the advanced care, advanced NRP, a person trained in advanced NRP urgently. If the heart rate remains more than 100, then this baby can be managed by ventilation alone. So you continue giving ventilation, and every 30 seconds you keep checking the heart rate. So that's all about prolonged ventilation. Prakash, please show the video number 6, that is prolonged ventilation, and then if there are any questions and if time permits, we can discuss them.
Bag and mask ventilation after 30 seconds. Following 30 seconds of effective ventilation, you must assess the baby's breathing status. If spontaneous breathing has not started, immediately call for additional help. Request another healthcare worker with NRP training to assist you. Connect the oxygen source to the bag. Attach oxygen reservoir only if you require more than 40% oxygen concentration. For lower concentrations, continue ventilating without reservoir. Now, evaluate baby's heart rate. Use a stethoscope for accurate heart rate assessment. Position the stethoscope on the left side of the chest. We can auscultate for the heart rate for about 6 seconds, and whatever is the heartbeat in the 6 seconds, multiply that into 10, which will give us the heart rate of the baby. For example, if we auscultate around 12 beats in the 6 seconds, 12 into 10, that is 120, is the heart rate of the baby. After 30 seconds of effective bag and mask ventilation, if the heart rate is more than 100 beats per minute and the baby is breathing, begin reducing your ventilation rate gradually until you stop completely. Check that breathing quality is adequate or not. Good breathing is characterized by vigorous crying or regular rhythmic chest movements. When breathing is adequate and you provided ventilation for less than 1 minute in total, transfer the baby to the mother for observational care. After 30 seconds of effective bag and mask ventilation, the heart rate remains above 100 beats per minute, but the baby is not breathing spontaneously, continue bag and mask ventilation. Reassess breathing status every 30 seconds. When the baby initiates breathing, progressively decrease your ventilation rate and eventually discontinue bag and mask ventilation. If you have provided bag and mask ventilation for more than 1 minute in total, transfer the baby to post-resuscitation care rather than observation care. After 30 seconds of bag and mask ventilation, if the heart rate remains below 100 beats per minute, immediately verify for adequacy of chest rise. If chest movement is insufficient, implement corrective steps again to improve ventilation effectiveness. Continue bag and mask ventilation without interruption. If your facility lacks a healthcare personnel trained in comprehensive neonatal resuscitation program, arrange immediate transfer to a higher center. Maintain continuous ventilation with bag and mask throughout the transfer. When to stop resuscitation? Continue bag and mask ventilation until the baby establishes spontaneous breathing. However, in certain circumstances, stopping may be appropriate. If there are absolutely no signs of life at birth, meaning no breathing, no heart sounds, and no movements, and this absence persists beyond 20 minutes after birth, ventilation may be discontinued. If any signs of life appear during resuscitation efforts, continue those efforts for a full 30 minutes before considering termination. When withdrawing or withholding resuscitation, our focus must shift to ensure the comfort and dignity of both the baby and the family. So to summarize the learning points which we have learned in this video, the first thing is, after 30 seconds of ventilation, assess for breathing. If there is no breathing, call for help immediately. Attach oxygen source and attach reservoir if more than 40% of oxygen concentration is required. Assess for the heart rate with a stethoscope on left side of the chest. After 30 seconds of ventilation, assess for heart rate and breathing. If the heart rate is more than 100 beats per minute and the baby is breathing, wean and stop ventilations gradually. If the heart rate is more than 100 beats per minute and the baby is not breathing, continue ventilation and reassess after 30 seconds. If the heart rate is less than 100 beats per minute and the baby is not breathing, call for help immediately, and if there is no trained person in the facility, arrange for transfer and continue ventilations during transfer of the baby to higher center.
Yeah, thank you. So, yeah. So, am I audible?
Yes, you are audible.
Yeah. So, if there are any questions, Dr. Bijender, you can put those questions. As I said,
Sir, many
for
questions,
prolonged
but sir,
ventilation, just remember HOD, H for heart rate, O for oxygen, and D for doctor or advanced care.
sir, many questions are there, but time slot not allowed, so we can move for the
I
next
think,
slot.
Dr. Prajan, sorry, Dr. Akash, I have
Yeah.
one question constantly asked in the chat boxes, so that
Yeah.
the video demonstrate opening the mouth and what to do. Would you just shall we take one stand on it so that people understand what to say in it?
Yeah. So, I would invite comments from other panelists also. But my answer to that question is understand that corrective steps are basically to ensure effective ventilation. Now, effective ventilation most of the times is because of a leak somewhere from the between mask and face or a blocked airway. So, if you take care of basically mask reapplication and reposition of head, most of the problems will be solved. Most of the problems will be lying there. Suction and increasing pressures are two more corrective steps that are to be done if after M and R the chest rise is not there. For some reason, the government module has removed O, which is open mouth.
Yeah.
So,
Akash,
because,
I would,
yeah.
Akash, I would like to add something. Why this open mouth was there? It is only for very preterm babies where the nares, because when we ventilate a baby with bag and mask, the air passes through the nares of the baby. But what happens, suppose when there is a very small baby, a preterm baby, and nares are very small, then the air may not pass through that nares to the lungs. So for a special situation like very preterm babies, it is required that you should open your mouth with your finger and then apply the mask and then ventilate the baby. So in most of the situation, it is not to be used. So therefore, we have removed it from the basic NRP because very preterm, 24 weeks, 25 weeks, only it is there. Or if there is obstruction to nares. So it is a very rare situation and we should not discuss about this. So please focus on the 4 points that Dr. Akash has said and don't give more stress on open mouth. We have very less time. So you should, in that 4 hours training, you should be able to tell the participants or give them the skills to ventilate the baby. That is more important. Thank you.
Agree.
Can I
One more
suggest
question
something?
that is,
I think probably would say
yeah,
that
please go
if in
ahead.
case they by mistake, if in case you say opening the mouth, do not have to reverse it. Just continue with it, and also have a faculty meeting, and just discuss on what you're going to say, so that just to maintain uniformity. Because opening the mouth is not wrong. So just to decide what to say, and then say if it by mistake you say also, just continue with it.
Yeah, that's fine. But if you
So,
don't, if you don't use it, you have the government manual to back you up. So that's fine, perfectly fine.
So we have to follow this PCL, what we are providing all of you. Don't get confused because you have very limited time, right? And you have to teach them. So
Yes.
please follow the PCL. It is clearly mentioned in the PCL and follow the PCL. I know many of you are the advanced NRP trainer or trained person. So there are this thing. such things are there. So don't get confused here. Here, most of the participant would be the nursing staffs, right? NM. So don't get them confused. Just follow the PCL. Right?
Just to re-emphasize, in the PCL as well as in the algorithm, it is MR and SP. Only these four steps are there. One more question that is popping up in the chat box is 30 seconds pay observational care or post-resuscitation care. Please remember, this is different from advanced NRP. We again and again are requesting you to switch to the basic NRP mode, go through the PCL properly. In PCL, it is very clear that brief ventilation wala bachcha will go for observational care. Prolonged ventilation wala bachcha will go for post-resuscitation care. If there are no further questions, then we can go ahead for PET, which is another important segment.
There are many questions are there, but time slot are not allowed for the same. We can take in last Q&A.
If there is any important question that Akash can give answer, otherwise we can move to the next session.
Yeah, Brijender, we can post in the chat box also. Akash, you can type in that chat box now.
Yeah, I'll type in the chat box because right now I cannot see the chat box. So I'll after this session I will type in the chat box.
You type in the chat.
Akash, do you see question and answer there, Q&A?
Yeah,
you have to click on that. You're able to see? No, because I'm able to see. That's why I'm asking you.
Prakash, I'm able to see that, but I can't talk and type at the same time. So after this session, I'll type.
Yeah. Okay.
Okay. Thank you so much.
Thank you, Akash. That was a very important session because, as you know, basic NRP, we always concentrate on the most important step in resuscitation, which is PPV. And PPV station is divided into brief ventilation and prolonged ventilation. So that is the most important difference from advanced NRP. So like everybody has been telling you before, please switch over from advanced NRP. We are teaching basic NRP and we are going to have a lot of people who are attending this course for the first time. And that is also the strength of this program, I think. Now we are moving on to the next session and very, very important session. How are we going to evaluate the participants at the end of the course? This is going to be done by using performance evaluation test, the PET forms, because there were a lot of questions in the chat about difference between PCL and PET and what is this. So the performance checklist is a checklist that we use at every station. You can even start off your station with a PCL, but a PCL needs to be used at every station. The PET is what is used at the end of the course. After you've completed your stations, you will be using the PET. Over to Vikas sir to discuss about PET.
Yeah. Thank you, Sharanya. Now, regarding this PCL and PET, the PCL is for practice. Okay. So we practice the resuscitation skills in pieces. We have 6 PCLs. So we are doing preparation for birth. We are doing initial steps. We are doing bag and mask ventilation or all these things. Now, what is PET? In PCL, we don't have any time limit. The participant can take his own time and perform. This is for practice only, to memorize the steps and how to do it correctly onto the mannequin. Now, after this training comes the performance evaluation test, in which there are 2 important things. First is that the PET should be done in real time. As the baby is born, what is our goal? Our goal is that the baby should get ventilated within 1 minute of life. So this has to be interpreted in this PET. So when the baby is born, we should see how the participants work on this and how they perform ventilation if the baby is not breathing within 1 minute of life. So for this session, what is important is, first, as an instructor, you will demonstrate how to do PET. Then the participants will follow. Please remember this. You see how you will do PET and you should not falter in timing. So you should practice this PET at your home before going to the training. Otherwise, it will not be good in front of participants. You will not be able to do in time. So, the performance evaluation time, the first thing is you will assess risk factors and demonstrate preparation of equipment and supplies. Again, I am saying because of the dearth of time, we have only 75 minutes and this PT has to be done by every participant. So, we will get only 5 to 6 minutes each participant. So, what you will do is the risk factor demonstration and preparation and equipment and supplies, because it takes a very long time. So what you will do is you will show them, you will tell one or two participants to do it, but afterwards you will start from the delivery of the baby. So this is preparation, equipment and supplies. If the time permits, you can do it with all the participants. If the time does not permits, at least one or two participants should show it, or you yourself should show how to assess risk factor, demonstrate preparation and equipment and supplies. But the rest of them will start with function of bag and mask and delivery of the baby. Now, in this performance evaluation test, there are three columns: 0, 1, and 2. 0, if the participant does not do that step, then you have to tick on 0. If the participant do the particular step, but he has not done it correctly, or he has not done that step in order, then you will tick on 1. 2 number you will give when the participant has done it correctly and at the correct place, then you will give the number 2. For this training, for the sake of this training, I am again saying you, as it is written, that student must perform each of 5 bold items correctly. What are the 5 bold items? First is they should test the function of bag and mask. Second is they should know when the baby will require positive pressure ventilation, because after initial steps, if the baby is not breathing, they should say that now this baby will require positive pressure ventilation. Third point is take corrective action if chest rise is not present. So they should know that chest rise is not present. And then the most important part is ventilate for 30 seconds effectively with chest rise on the baby. And then the fifth point is that the person should call for help, add oxygen, and count heart rate if the baby is not breathing after brief ventilation. So these are 5 points. For the sake of this program, I would say you at least your participant should start the ventilation within 1 minute of after 1 minute of birth. You should check the time. You should imitate that the baby has been born, and then you should see whether in 1 minute the person is able to start the ventilation. And after starting the ventilation, if the healthcare workers is able to do effective ventilation for 30 seconds, then you can pass that participant. Don't be very strict. Only stick to two points. Don't go into further details. Even if the participant is able to first start the ventilation within 1 minute and do effective ventilation in 30 seconds, you can pass that particular participant. And remember, in the previous workstation also, your focus should be that every participant should get enough time on mannequin to practice bag and mask ventilation. There are two things in bag and mask ventilation. First is how to make seal. There are two different ways to make seal. One is C type, E type. Then if there are two persons available, he can make a seal with two hands. Two hands. And the importance is of seal, and then maintain the correct rate and rhythm. Remember, when you are anxious, when the baby is not breathing, always you will not maintain the required rate. You will ventilate with a very higher rate. So you should always speak out, breathe 2, 3, breathe 2, 3, breathe 2, 3. Make sure that the participant always speak out when he is ventilating, he or she is ventilating. Otherwise, what will happen? They will ventilate at a very high rate. Breathe, 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 breathe. They will do it like this. So please tell them, please speak out, breathe 2, 3, breathe 2, 3. This is the crux of training. First is how to make a seal properly, and then how to ventilate properly for 30 seconds. So in this piece, PET, this is very important. And remember, you should lead, you should show them how to ventilate. If you are not prepared, you will fail. I remember when I first went as an instructor, my teacher told me to practice 1,000 times on the mannequin. So this is the key. You see all the videos, you practice, don't discuss theory. Don't discuss theory. Show them how to do it. Showing them is more important and doing is more important. If some step is missed, it is of no importance, but you miss how to ventilate a baby, because I have seen in many trainings that they are giving importance to all other things, but they are not showing how to ventilate baby properly. Even the instructors are not able to do it properly. So as an instructor, I request you all have mannequin with you with bag and mask, you first practice yourself how to properly ventilate the baby and then show them, practice them. So this is the crux. So again, I am speaking in PET, time is very important. Second thing is, two things you have to see, that the baby should be ventilated within 1 minute, and the baby ventilation should start within 1 minute if the baby is not breathing. And second thing is, the person should be able to ventilate the baby effectively in 30 seconds. Suppose a person is healthcare worker is not able to do it, then you stop that scenario, tell that person to come in the end, give him a second chance, let him see what others are doing, he will learn, and then give him another chance to do it. And if you do it properly, then you can pass the participant. Any questions or any Brijender?
Yes, sir.
Yeah.
So, sir, next question is what liter O2 to start with, and how will we know the 5O2 requirement and how to adjust where there are no O2 blender?
There is no, in this basic NRP, please remember,
Yes, sir.
come out of your mindset of advanced NRP. Come out of your mindset of advanced NRP, whether we require 40%, 100%, it doesn't matter. If the baby is not breathing and heart rate is less than 100, you have to give 100% oxygen. Is it clear? Is this clear to everybody? Or is there any sense? If the heart rate is less than 100, you have to give 100% oxygen. Any other question, Brajender?
Sir, yes, sir. So, how to assess the requirement percentage of oxygen when we need to connect a reservoir?
I have already cleared it, na Brajender? If in this basic NRP, we don't have any pulse oximeter or anything. So what we are talking is, if the baby heart rate is less than 100%, less than 100, then you have to attach the oxygen and you have to give 100% oxygen. Is this clear?
Okay, so can we move to the next? Charanya? Okay, I think there is no more question, Vijendra. So I think now, can we move to the next?
Yeah. Yes, sir. Thank you, sir. Pardon my video. We had a power cut at the exact moment that I'm supposed to talk. But I think we are moving on to the most important session, which is a lot of doubts. We've been receiving a lot of queries about logistics. And we have been trying to answer all the queries on all the WhatsApp groups, but I'll just go through the entire flow of the course now. And at the end of the session, we'll take queries about all the logistics. So I've divided the session into 3 parts, which is pre-course, during the course and post-course. What are the responsibilities of the instructors and the course coordinators? So the most important thing pre-course is to ensure enrollment and registration of all the participants. And I would like to take this moment to inform you, just like the election results, we've been having live results of all our courses and participants that we've been sharing. And we have reached 998 courses as of now. So just too short of 1,000 courses. And we have 18,077 participants registered on the portal. And out of that, 13,000 have already completed the pre and post test. So that is a great number. But we would like all the course coordinators to ensure that all your participants, the estimated number of participants, get enrolled onto your dashboard. And the other thing to ensure is your instructor to participant ratio and your mannequins. Please ensure that you have the mannequins and make sure that the mannequins are working so that we do not have any problems on the day of the course. And ensure that your venue has enough space for the tables and the equipments to be arranged. The equipment checklist has been shared on both the folder, I mean on the course coordinator folder. So at least a day prior to your to the course, please ensure that the equipments are ready. The banner and the backdrop has also been shared. Now this can be printed out. It can be a flex, or it can even be a soft copy at the backdrop of your the course where it's being conducted. So it is totally up to the course coordinator to take that call. As for refreshments, it's a 4-hour course. So refreshments can be arranged as per the venue. And we want you to have good communication with the participants so that that there is enough participant engagement and to ensure that they turn up on time so that it's the course does not, we stick on to the agenda. It would be good to have a faculty meeting maybe a couple of days before the actual course, so that all the faculty and all the instructors are on the same page as to when to start the course, what is the agenda, how to stick to the timing, and what are the points that are going to be discussed at each station. Now, I just want to show you the course coordinator dashboard. Is my screen visible?
Yes.
So, just a minute. So your if you click on your course coordinator link, it will take you to this page where you sign in with your course coordinator ID. And this is your dashboard. So in your dashboard, you will see a tab called My Courses List. And all the courses registered under you, some people might have one, some might have two. The courses will show on your dashboard. So please go to Action. Green means your course has been approved. If you go to Action, you will actually see the number of expected participants and the number of participants that have already registered. So scroll down and go to Manage Your Course Roster. Now this course roster will show you all the registered participants and their details, their phone number and the date at which they have registered. Now, on the day of the course, if you want to mark attendance, so this is the Excel list that, the dashboard that you will see. So in case you want to mark their attendance, not in case, actually you need to mark the attendance, go to Edit button and you will see a result or attendance tab. So you can actually choose pass, retrain, or absent if the person didn't turn up. So this acts as both a result page and an attendance page. So say at the end of PET, you are marking this person as passed. And here you see a choose file. Now, if you go here, if you have a soft copy of this particular person's performance evaluation test, if you have taken a photograph or a PDF copy, then you can attach it here. So it will show up as a file and you can save this. Now, once you have saved that, on your dashboard, again, it will show you that you have saved a document and this person has passed. So at the end of the course coordinator has to ensure that the list has been completed. Even before the course, please log into your course coordinator dashboard, go to my courses and ensure that all your participants are getting registered by making sure that you're reaching the registered number as per your expected number. So this is something that you will have to do before the course. Now, during the day of the course, so once the participants start walking in, you could have a registration sheet at the front desk or at the beginning of the course. Again, for this registration sheet, you can just use your same course roster. So if you go to your course roster and do an Excel sheet, there's an Excel option here. If you click on Excel, so it will generate a complete attendance sheet for you, where you will have the participants and you can actually use this as a registration sheet as well. So as and when participants come in, they can sign on the column and this will become your registration sheet. So you don't have to create another sheet, you can use the same sheet. Now, once registration is done, divide your participants into batches of 10 and assign them a table. And the faculty also need to be assigned to each table. Say, for example, you have a course of 40 participants. So 4 groups of 10 each will be allotted to each table and 1 faculty to each table. Now, like it was already mentioned by Dr. Vikas, the faculty will rotate and the participants will remain stationary at the same table. So we've already discussed about doing PCLs at each table and finishing your course with doing the PETs. Just for the benefit of those who have not seen the agenda, so the agenda goes like this. There's 15 minutes for registration and for you to have maybe a brief introduction to the course. So session 1, which is preparation, we have 30 minutes. Session 2 for routine care and initial steps, we have 30 minutes. Session 3, which is PPV station, we have 75 minutes. And for performance evaluation, we have 75 minutes. So once the performance evaluation is done and the PET forms have been collected by the course coordinator, then we finish the course by doing maybe completing the session, a brief talk, a photo session, video session, and feedback. Now the video can be done, instead of doing it at the end, can be done during the course of the session, a 1-minute video to show the tables, the faculty teaching the participants and all the participants in the course. This is to ensure that we do have some proof of all these courses being done in all the across all the states. And the photo session, we need 2 pictures which are mandatory, one at the beginning of the course and one at the end of the course. This is again to ensure that we do maintain the quality and uniformity of the courses. Take a geotagged and timestamped photo at the beginning and one at the end of the course. Now these photos and videos can be shared on your state WhatsApp groups. Every state has a WhatsApp group, and these will be collated by the state coordinator. Now, the good thing about these WhatsApp groups is the people from the central NNF office are also on the group, so they will also be able to help the state coordinators collate all this data in the end. Now, this is during the course. Post-course, like we already said, so there are 3 ways in which the PET forms can be submitted. One is individually take a copy of each PT and upload it on the dashboard like I showed you. Or the other way of doing it is, just a minute, I will just show you. We have created a online PET form. So we will share the Google link with you shortly after the session. So instead of doing a paper copy of a PET, you can use this online Google form also just on your phone to assess each candidate. So this you will need just basic details like email, the participant's email, course ID, instructor name, and name of the candidate. And just like your PET, this has all the options. So 0, 1, 2 can be marked. So finish this and mark as pass or reevaluate any remarks that you want to write here and submit this form. So this is a completely online form. If you do this, you do not have to upload a PET form separately. But if you are using a paper copy, please upload the form either individually on the course coordinator's dashboard or collate all your forms, make a single PDF and share it with your state coordinator. So there are 3 ways of uploading your PET forms. Now, we also want you to take a printout of the participants list at the end after you've marked the results. The results will be marked on the dashboard. So please take a printout of that particular form as an Excel sheet or as a PDF form. And please sign the form and place your stamp on it so that this also will be another way of knowing that this is authentic and has the course has taken place. Like I already said, the pictures and the video can be sent to the state coordinator on the respective WhatsApp groups. So this is post-course. What about certificates? There are 2 types of certificates. One is an attending certificate and the other is the provider certificate. So for the attending certificate, the format has already, the soft copy has been shared on the course coordinators folder. Now, this is not mandatory. Many centers had requested us that they want physical certificates to be given away at the end of the course. So it is totally up to the center and the course coordinator to take a call on this. If you do want to distribute physical certificates, please take printouts and physically fill in the details like the participant's name, venue, and it does have a place for a sign of the course coordinator and the lead instructor. And this can be given to all participants at the end of the course. Again, this is not mandatory. As for the provider certificates, for all candidates who successfully complete the course, the e-certificates will be sent to them once the results have been collated and all the results have been verified. What about results of the post test? That also many people have been asking. So we are just waiting for all the participants to complete enrollment and complete their post tests. Once this is done, the post-test results will be sent to each course coordinator individually. So you will have those results before the day of the course. And this will come into play only when you have a doubt about anyone's performance evaluation test. So say the participant has been extremely good and you have passed the participant based on just the PET, you will not have to look at the post-test scores. Suppose there is somebody who's borderline and you are unsure whether you want to reevaluate or if you want to give pass, then you can look at the post-test scores and make a final decision. Now, yes, for us to be able to send these scores across to all the course coordinators, we do need at least 2 days to collate all these results and send them over. So we please request that, you urge all your participants to complete registration in the next 1 day. We were actually supposed to close all our participant registrations today. Today is the 6th, so by midnight of 7th, please ensure that all your participants have not just enrolled, but also completed their pre-test and post-test. I think we have covered, yes, a very important thing about maintenance of mannequins. So whether it is mannequins arranged by each center or whether it is mannequins sent over from central NNF, please make sure that the mannequins are being maintained because they are, with like Vikas sir was mentioning, with turning of the head to one side, Prakash sir was mentioning, there is a possibility that the tube gets cut off and then the mannequin is not usable at all. So please ensure that there is no liquid leakage or no damage to the mannequin. This also is a very important aspect of conducting NRPs. I hope I have covered all logistics. Akash, anything that I have left out? Lalan sir?
No, you have covered almost all the aspects, Saranya. The only one thing I want to add is that for authentication point of view, after completion of the course, the course coordinator has to sign and give their stamp and also take signature of 1 or 2 person who is not part of this course, right? So that would be the witness that this course has been completed. Otherwise, you have covered everything. Dr. Akash, anything you want to add?
No, sir. Most of the
Okay,
things are covered. Yeah.
There are some questions are in Q&A situation.
I think
yeah. Please.
Post-test, when should it be completed? Yes, please try to complete post-test by tomorrow, enrollment and post-test. So we have some time to collate the results and send it over to the course coordinators. Somebody has said I'm not able to access my dashboard. Please ensure you're using the correct course coordinator ID. If you're still having problems, get in touch with us, one of us at NNF office, and we'll be able to help you out. Extend deadline for completing post-test. We are 3 days away from our course. So yeah, we would like that everything is done by tomorrow so that, we can start collating all our results. So please push your participants to it. It actually doesn't take too much time. It's a very, if they have just 45 minutes to 1 hour, they can complete the entire pre-test videos and post-test, and they do not have to log in to watch the videos. Actually, the video links have been sent separately also, so you can share it with them and they can watch it in bits and pieces also whenever they have time, and then complete the pre and post-test. So that is also a possibility. Some centers have not received mannequins. I think the mannequin status is being shared on all the state groups. So if you can just share the mannequin status on the state groups, the state coordinator also will be able to take your queries.
Lalan sir, there is one question about what you said about witness. Can you please tell that again? Sri Sailam has written, please repeat that.
So Sri Sailam, we need to get the document, the attendance and all these things signed by the course coordinator, and we need to take 2 witnesses, right? कोई चौकीदार होगा या कोई भी anybody from your hospital, you can just take the sign that means that we have conducted this course, nothing else.
Anyone apart from the participants?
Anyone apart from the participant as well as the instructor.
Instructors.
Yes.
There is one more question: how to cross-check whether participants have completed pre and post test? as of now, the course coordinator will not be able to see that. So we request that you ask them to send you a screenshot of their completion. They will get a final page where they have submitted. And if they have given an email ID, they will also get an email which confirms submission. But like I already mentioned, if everybody finishes by tomorrow, then we can collate all the results and send it to you. That will be proof that all your participants have finished the post test. How to see my participants' course ID? Your participants will be registered under your course ID. So they should be registered. You should be providing them with your course ID to register. Are there any other questions that I'm missing?
Dr. Arun Kumar Manglik has asked a question that if the neonatally, water fillable neonatalies are not available, then can BLS mannequins be used? So any mannequin that can show chest rise or that can show ventilation effectivity can be used.
There is one more question. Participants are entering into other courses. Yeah, this is exactly why we want you to give them the correct course ID and ask them to register into those courses, because we're having a lot of requests for deletion of participants and which is extremely difficult at this point because we're 3 days from the program. So please ensure that you give them the correct course ID. But if there have been errors like this, get in touch with the office and we will be able to correct it for you. Can we add?
Ma'am, one question. The this online PT Google form is to be done on every participant's phone or on evaluator's phone for each participant.
Sorry, I didn't get. The PET is to be done for
each participant by their mobile or from evaluator's instructor mobiles for each participants.
Instructor mobiles.
Instructor's mobile. Yeah. It is to be accessed only by
instructor
the
mobile, and
instructor.
also for each participant, one form should be filled.
And if you are not comfortable, please take the hard copy and do on that.
Yeah. Also, please ensure the Google form that we are sharing is not shared in your course WhatsApp groups, because that is to be accessed only by the instructors and the course coordinators, not by the participants. So that's extremely important, that access is limited only to course coordinators and instructors.
Ma'am, one query. Dr. Seetal asking, she has 16 participants and only one instructor and one mannequin. How to conduct this course actually?
We will have to ensure the 1:10 ratio for mannequins and instructors. So either try to source another mannequin and an instructor, or you will have to restrict your participants. Maybe ask them to
they can do 2 courses.
2 courses,
right?
correct.
One in the morning and another in the evening. That will be better.
Yeah.
Sir, I just wanted to add one more point. For the PET forms, we are doing it online. We will be able to share a viewing Excel sheet in case you just wanted to see whether all your participants have entered. You may have to download that sheet, sort the course IDs, then you will be able to see what are the participants are there in your where they have registered in your course. But you will only be able to view, you won't be able to edit. So in that which case, you may have to download that sheet and then do your manipulations.
So, is there any other questions? I think Dr. Om Prakash has raised hand. Can we unmute Dr. Om Prakash? Or you can just write down the question, sir.
Ma'am, Dr. Dinesh asking, any chance to edit the participant list, those who already registered by mistake? Please clarify.
Only office
Yes.
can do.
Yes.
Other option is should they enroll into 2 courses and participate in the course they are supposed to, and anyway it will be marked absent in the other course. So that is
Correct.
one other way to include them into your course.
Sir, video to be taken during the course at what time, please?
Any time during the course. It just has to show your venue, your arrangement, participants, and the faculty being present.
Sir, asking about the instructor certificate.
Yes, all faculty will receive a certificate at the end of the course. Yes, if we
Sir,
don't
asking
have
about the
sorry, Rajendra. If we don't have the neonatally, if you do have an infant mannequin which shows chest rise, because there are 2 types of mannequins. One is only for chest compressions. It does not show chest rise. So if you do have one with chest rise, yes, you can use it.
I think there are some more questions related to instructors, lead instructors, etc. These we can give a general answer that these can be discussed with the state coordinators.
Right.
Yes.
Every question won't be able to be answered here on this platform.
So can we conduct course on some other day? Yes, definitely you can conduct course on some other day. The only thing is it will not come under this particular initiative. This particular initiative is 1 day, 1 nation, 1 mission. So we're trying to do it as a single day, multiple venues initiative. So people who are unable to source mannequins or instructors, yes, you can do it in another day, but it will not appear under this initiative. One more is
Hey,
when
that,
should
that
They can do
particular,
as 2
hey, that
courses
particular
also, no?
question, yeah, that particular question says 20 nurses in 1 day. So do 2 courses, no? Pre-lunch,
Yeah.
post-lunch.
Yeah.
Dr. Soma, do 2 courses. Do it on 10th May only.
Is there a scheduled time by which it should start? No, there is no scheduled start time. If you look at the agenda, we have only mentioned the time for each station. So whether you start at 8 or 9, it is the course goes on for 4 hours. That's the way agenda has been designed. So people who are doing 2 courses are doing 9 to 1 and 2 to 6. So you can pick any time.
No, the only thing is if they have very less number of participants, then it may not require 4 hours. Suppose they're doing for 5 or something like that, then probably the time will really come down.
Yeah,
But the
definitely.
minimum
Yes.
participant is 10, right? We have kept 10, no? Saranya?
No, sir. No, sir.
Minimum-
Maximum per
minimum
instructor
for-
is 10, but then even
Yeah, yeah.
So we don't have any course which has gone below 8. So the
Below.
lowest that we have in a course is 8 in some of the remote areas.
Some of yes. So,
Sir, Hari Kishan sir asking about the can we allow more participant and add a instructor in the course ID already registered?
yes, you can, but you have to inform the office, they can edit that.
sir, more than 10, sir.
No, they can add the instructor as well.
Is there a cap for each course, sir? 40 per course? Or they can do more than
no.
40
No, there is no upper
with
cap.
appropriate
Yeah, if
instructor.
you are having a mannequin and instructor, you can go, there is no upper limit. People are doing
Yes, sir,
100
but in when they register, they can only enter 4 instructor name.
That has been edited, sir. So we have gone up to 7 at the most because that was a
Okay.
request. It was the
Right.
highest request. So right now we can add up to 7 in one course.
Ma'am, actually many centers asking for the 2-3% extra, like 40 is registered and 42, 43, 41, 44, then we can allow or not?
So they, as Akash has said, they can discuss all these things with the state coordinator.
Okay,
Akash,
sir.
Alan sir, one question is Dr. Hunsigiri is asking, can we make the ratio as 1:12? You have to take a call on that, I think.
again, depends upon, they can take the call at the local level. Suppose you have one mannequin, one participant, and suppose one more participant come, you cannot deny, right? It's better
Then you
to,
have to increase the time of training.
yeah,
You will
you
have to increase the time of the training.
right.
But if
Yes,
possible, stick to the
yes,
ratio.
right,
Stick.
yeah, we need to
Or
stick
either
to.
we have to increase the time, 5 hours, 6 hours. He can train that.
Any other
Yeah, I
questions?
think we can wrap.
Okay, so it was excellent session. So may I request our treasurer, Dr. Ravi Sachang, to propose vote of thanks. Thank you, everyone. Thank you very much for the excellent discussion, and all the faculty members. Thank you very much. Over to Dr. Ravi.
Thank you, sir.
Thank you, sir, for giving me the opportunity to present my vote of thanks. I sincerely thanks to all the national coordinators and zonal coordinators, state coordinators, faculty members, and all the participants for making this momentum a true national program. And we are treating the frontline training and the frontline healthcare worker, creating a capacity building in a major scale, which is at a global level. And thank you, sir, for your our president, sir, for visionary leadership and guiding us all throughout this program. And I can assure you, sir, that all our teams are working day and night, and we'll make it a true vision for this. And I thanks our honorary secretary, Dr. Amit Upadhyay, sir, for he's making the tireless effort to make this program successful. And our IEP mentor, Dr. Vikas Goyal, he has an already and always give a very grassroots, very critical input which are required for the execution of the program. And Professor Akash is very meticulous in all, sorting out the queries and detailing all the fine things. And special thanks to Saranya. She is not leaving any stone unturned to make it the grand success. Planning and executing in a very grassroots level and connecting to the such a mass scale is not an easy job. Thank you so much, Saranya, for your putting an extra effort, extra mile, to making it a success, grand success. And then it's all about the participants. So I can only say just keep this momentum high, keep your juice high. We are at the level of making a history, and probably we'll make it with a great success, grand success, which is never in the history. It is never precedented. So thank you so much for
And
such
also
a
our
late
office
night for
staff,
joining.
and Ravi, and also our office staff who is
Yes,
working
yes, sir.
day in, day and night.
Yeah,
Devarun, Jayan, and the new staff, all staff.
everybody is our office executive, right from the every staff member and office.
So,
The
yes,
people are working very
Devarun,
hard.
Sunu, and Jayant, everybody is working very hard.
Yeah, yeah, and Neetu ji also, and she's also planning for that. Thank you everyone for joining so late. Thank you, sir. Thank you.
So, Saranya, any housekeeping? Are you going to do this course again if somebody has not joined, or
Yeah. So,
Akash ji?
Yeah, so if there are enough people who have not joined today, then we can take one more session tomorrow. Similar, same time, we can have another session. But maybe you can take a call, sir. If there are enough people who say that they have not been able
We
to
can
attend,
review. We can review the attendance, and then we can take a call on that.
yeah.
Right. Okay.
Maybe
Thank
we
you
can
so much.
communicate on the state groups, sir. We can put it on the state group.
Yeah.
See if enough people are available for tomorrow. We can do the same session tomorrow.
We can put a poll in all state groups. Have you attended today's session? Yes, no.
Yeah,
That will give
correct. Yeah.
And if the majority is not joining, and then if they are willing, then they can join. If
Yeah.
if even then for today's session, if they want to further clarify, they can again join. So let the people decide.
ठीक है.
Okay.
Okay, sir. Okay,
Screenshot
sir.
ले लिया
Thank you.
sir?
Thank you,
What about
everyone.
the
Sir,
screenshot ले लिया? नहीं.
screenshot, sir. Yeah.
Yeah.
Okay. Ready? Yeah. Thank you.
Thank
Okay,
you.
thank you, sir. Anya. Thank you.
Thank you so much. Thank you. Bye bye.
Thank you
Thank you.
very
Thank
much.
you, sir.
Good night.
Sir.
Bye.
Bye.
Good night. Thank you.
Bye.
Bye-bye.
Bye,
everyone.
Akash.
Good night.
Yeah. Thank you, all of you.
Good night, sir. Good night, sir.
Night.
Thank
Night.
you all.
Night.
Thank